Beyond Hospital Doors, Through the Eyes of a Surgeon, an interview with Dr. Kelly Casey. Sidney Regional Medical Center presents a new podcast series. We are taking our signature health and wellness profile and breaking it down into episodes where we will speak with our providers and top experts on issues that extend beyond hospital doors. In this podcast, we feature Dr. Kelly Casey, a general surgeon who is rated as a top general surgeon and who is known as the Miracle Man through the eyes of a few of his patients and medical staff. Dr. Casey is a part of the Sidney Regional Medical Center's specialty clinic and travels in other parts of Nebraska, sharing his skills, his talent, and his knowledge. This is the topic of Through the Eyes of a Surgeon, a talk with one of our leading healthcare providers and general surgeon on his pre-operative, operative, and post-operative aspects and the plan of care. It is a fact that general surgeons are in some ways the most talented doctors in the hospital setting because they're very well trained, very well rounded, and the hospital depends on them to take care of the most sickest of patients. General surgeons are the backbone of most hospitals. Dr. Kelly Casey specializes in trauma, acute care surgery, GI surgery, hernias, breast cancer surgeries, colon cancer, just to name a few. Join us as we go beyond hospital doors. As I will be your host, this is Kimberly Dreyer. Dr. Casey, welcome.
Thank you.
You have an amazing track record and your journey as a surgeon. And you didn't quite start out as a surgeon. Here, I'm going to go to med school. I'm going to do family practice, yada, yada, yada. No. You kind of went to a trajectory of different paths before you actually found your passion as a surgeon. Could you just kind of talk a little bit about that so our listeners can know a little bit more about you?
Well, sure. I guess first off, I was born in Omaha. My dad was in dental school in Creighton, and soon after that, we moved out of state, and I ended up growing up in Washington State, in a very small town in the northeast corner of Washington State. Newport, Washington is a town of about 2,000 people, so a very small town. And he was the dentist in town. And growing up, I think he wanted me to become the next dentist in the family and take over that. And, I really didn't want to be a dentist, but I was intrigued by medicine. And we had some really good family practice physicians and in my town, and that interested me. So I was thinking medicine more than dentistry. And then he encouraged that, and I went to college. And then one thing happened after another, and I guess I got a lot of really awesome opportunities to do some amazing things. So I didn't go straight through.
So you didn't go straight through. So you were some kind of a fire trooper or something?
Yeah. Right out of, halfway through college, I got started in forest firefighting. I did a couple years on the local forest on an engine, and then I got hired onto a hot shot crew. And that's one of the type 1 or specialist firefighter crews, 20 people on a crew, and they just basically blast through the forest making fire line. So it's at the same level as a smoke jumper, but doing a different job. So we would work on the big, huge project fires and dig like 6 miles of fire line in a day.
And then somehow you had commented that you got into some kind of a construction.
Well, yeah, there's a couple steps in between there. I had planned on at that time switching over to a smoke jumper crew, but I got a knee injury at the time, so I couldn't do that. So I ended up studying Catholic theology and ended up getting a master's in Catholic theology.
Amazing.
Kind of on accident. And then from that, I had a friend who was a family practice physician who I often spoke with about, medicine about and becoming a physician. And then he actually went down to Honduras to volunteer in an orphanage. And at his recommendation, I decided to do the same thing. I'd always been intrigued by Central and South America and wanted to learn Spanish, and I thought it was a great opportunity. So I signed on for 1 year, and I ended up staying for 2. And I thought that I was going to be a teacher down there, but they ended up with the biggest need they had was for construction and maintenance, so I ended up sliding into that. And then right after we got there was a hurricane, Hurricane Mitch, and that was in 1998, and it took out a whole bunch of buildings. So I ended up being very busy repairing and building buildings for a couple years, and I actually kind of fell in love with construction. So when I got back to the States, I fell into this job where we were building hospitals. So 5 years I was doing that, and I was on this $200 million job building a really big hospital. And one day I came out of this big elevator bank, and there's this guy wearing a white coat. He's a physician, and I recognized him. I said, "Hey, I recognize you." And he said, "Yeah, we went to school at Gonzaga together." And I was like, "Oh yeah, and now you're a physician." So we talked about it, and a lot of things had happened in my personal life. I'd been taking care of my mom, who ended up dying of cancer, and my great-grandmother, who ended up dying at 94 years old. And so all these things that I was kind of very occupied with, suddenly the question was coming up again, like, hey, what do I want to do? Do I want to go back to medical school? So 10 minutes of talking to this guy, and I decided, okay, this is it. I'm going to go to medical school.
So did you pursue family practice? Did you pursue surgeon?
Yeah. So actually, yeah, when I applied for school at Jefferson Medical College, there was a tract that was specially designated for rural family practice.
Okay.
And I actually applied for and got into that. So I was in a special tract for rural family practice. And it wasn't until my junior year that I was on we call it OB-GYN rotation, where I took a week doing gynecologic oncology surgery. And these are really big surgeries, extensive surgeries. And I was in the operating room for a week, and I fell in love with being in the operating room and surgery. And it was a very difficult rotation, but I just fell in love with surgery, and that really changed the whole course.
That is amazing. And you somehow learned of Dr. Jensen, who is your colleague now. How did that happen?
Yeah, so after medical school, then you apply for a residency program, and the residency program you apply for is just based on what you want to do. So if you want to be a family practice, you apply to a position in a family practice program. I was applying for general surgery, so I went to my first interview, and this was located just north of Philly, an hour north of Philly. I was in this, it basically takes all day. So you meet about 5 to 15 other people who are also interviewing, and I met Dr. Matt Jansen on that day, and he seemed like a really excellent person. So, and the program seemed awesome, and it turns out that it really was. I've been rated the best surgery program in America on one category. I think it was 2 or 3 years ago. So I met Dr. Jansen, and I said, well, I really like this program. I think I'm going to rank this place number 1, but I want you to rank this place number 1 too, because if I'm here, it would be awesome to be here with you too. So he actually did, and we got accepted to the same program. So we spent the next 5 years in the surgery program together.
That is an amazing correlation. Sidney Regional Medical Center is honored to have you here. And in speaking with several families and finding about who is going to be my surgeon, one of the key, issues in through the eyes of a surgeon is alleviating the worry and or the myths about surgeries and the talent that we have here, and just simply your expertise. And it wasn't too long ago that I had a patient to come to me and say, please tell me who this guy is. Please show me his picture. And please tell me what he's going to do and his personality. And it was an honor to know about who you are and the things that you do, and just simply what the patients have to say about you. In this podcast, we would like to ask some questions about being a general surgeon and explore some interests and topics through the eyes of a surgeon. And with that note, let's go ahead and get to it and ask you a few questions. Your practice as a typical surgeon is not in a big city. However, it is in a rural Nebraska. What are some of the challenges that face you with rural medicine?
Well, that's a good question. Well, first off, it's not for everyone. I think growing up in a very small town when your dad is the dentist, everybody knows who you are, and I can tell you that in medical school and in residency, there's a lot of people who really aren't cut out for that. They want to disappear, and it literally they would say, like, I can't imagine going to the grocery store and having somebody say, oh hey, can you check out this rash, or bring up something, they just panic thinking that might happen. So it's not for everybody. But so yeah, being in kind of a remote setting or rural setting, one of the challenges is what do we do here versus what do we send out or pass on to a bigger institution. Because when you're in training, everybody comes to you. When they come from small towns, they come from other places, and you're the big place. And so you're used to just saying yes to everything and everybody, and you get these really big cases, complicated patients, and now you find yourself in a rural setting where it's like, well, we probably should send this where there's more resources, more diagnostic tests to do, and more support staff.
Which kind of leads me into one of our questions that we have here is at times, we here at Sidney Regional Medical Center have to sometimes send people out to other areas, Colorado hospitals. And under that note, is that due to the specialty of different MDs in those locations?
Yes. So yeah, it gets that's like I said, it's one of the big questions, like, should we take this on? Because really we can do the surgery here, but then post-operatively, the amount of care or ancillary services, diagnostic tests, we just don't have. And if you go to a regional center where they might have surgical residents, right. There's plenty of surgeons in-house all day long that are that's their job, is to just go to the rooms and check on these patients and stuff. So when here we're seeing patients virtually every day, and we've got all these scheduled cases, we only have Dr. Jansen and I, and with the addition happily of Sabre Peets, our physician assistant, who's been awesome, but we just don't have teams of people to follow up with the patients, and there's also a lot of diagnostic tests we just don't have.
One of the questions is that I get asked a lot, and so now we can direct it to you. What you like most about being a surgeon? Well,
I like a lot of it. It's a fantastic job. It's very rewarding. I have a lot of fun with the interactions I have with the staff. I mean, the operating room, that's one of the things I fell in love with right away, was in the operating room. You've got this teamwork, with anesthesia and the nurses, the scrub techs. There's just a really dynamic atmosphere. I like that. And then with the patients, one of the things that I enjoy as being a surgeon is that, frankly, I can spend more time and dive deeper into a problem, whereas with family practice, I felt that I wanted to go deeper into some issues, but family practice, they do an amazing job of seeing a lot of people every day, and they have to cover a lot of things very quickly, and it's hard for them to take the time, 30 minutes, 40 minutes, an hour to just dive deep into an issue. They just, their schedule, the nature of their job doesn't allow that, but I get to do that. Yeah. So I find that, so I get to personally know people and learn about them and their life, and dive deeper into the problem, where a lot of times it takes a little bit of out-of-the-box thinking to figure out what's going on.
That is very interesting. In some of the patients that I have worked with, both coming into the hospital and then, of course, discharged, they often call you the miracle man. And
I don't know where that came from.
Well, I think it is all about the presentation in when you first met with them, then they had the surgery, And then they're now going out and the passion that you have had with your patients. And it's quite an honor when you hear patients and staff saying, what a great job and a great surgeon that you are, and very passionate about your work. And one of the questions that some people have is, which will go right into your plan of care. How do you manage a patient who is in a critical condition and needing to be rushed to the operating room immediately? How do you handle that?
Boy, that can be that can be tough. I think of kind of two situations. One is a patient comes up to the office and their situation has just, in the meantime, after getting a referral or making an appointment, has just progressed to the point where they might have an infection or something like that. But now the infection is more advanced. So when they finally get to me, it's like, we take a look and we're like, wow, this needs surgery right now. So we're calling, the operating room and getting the patient admitted to the hospital and calling the operating room and saying, okay, well, if there's a surgery going on right, or they might have been planning for some other surgery, let's put that one on hold. We need a room immediately, so we get them down there right away. Or the other situation might be like a trauma, and in that situation, we come into the emergency room and there's a whole team of people, and the great thing is we all kind of know what we need to do. There's people who are drawing blood, the lab, and the nurses are putting in IVs, and we're checking the patient head to toe. We've got to get some x-rays and all these things. And, my role in that sometimes initially kind of like an oversight or directing traffic. And then every once in a while I need to dive in and, they might need some kind of a vascular access, like a central line or IV or maybe a chest tube. So I might have to do some kind of a procedure, hands-on, focused on that. Maybe they've got some bleeding and we need to stop the bleeding right away. But otherwise, I kind of try to step back and let everybody, do their job, and then kind of make sure that we're flowing in the right direction. And we don't want to linger. We got to get this patient into CT to get some diagnostic tests, or go to the operating room, or make the decision, hey, this patient is going to need a higher level of care. Let's get on the phone and get a helicopter in here fast.
Yeah, amen. What I've heard most about you, as well as Dr. Jensen and Sabra, is that you explain your procedures, that you explain, here's what we're going to do, here's what we need to do, and then afterwards, you keep it very patient-centered, patient contact, which is so important with your role.
Yeah, I do. And I repeat myself.
Which is good.
So, I think when there's a lot of stress when somebody's has a problem, they have the stress of having pain, or a problem that maybe it's a long-term problem, or maybe it's just severe abdominal pain, or what, or maybe it's the stress of having a diagnosis like cancer. Either way, it's hard. These are brand new ideas and complicated concepts sometimes, and can be overwhelming. So I try to very much speak in a way that people are going to understand the process, and they should know what we're doing, why we're doing it, how we're going to do it, and then what can go right, what might go wrong. They have to know what the complications might be, and then afterwards to have some kind of expectation about maybe postoperative pain, or how long until they can get back to their normal routine, or what have you. So I think that really helps people to put it all into perspective and kind of see the big picture.
Right on. So we are narrowing down to some of the questions in the last of our podcast. One of the questions that was asked to me to ask to you was, what is or was the most challenging situation that you have faced as a surgeon?
Yeah. So, we always have expectation that we do this surgery and this solves this problem. So it's hard when you do like, let's say a hernia repair, and it might be an inguinal hernia, and they might have preoperative pain, and our hope is that when we fix this hernia, the pain goes away. We fix the hernia, and sometimes the pain doesn't go away, or there's another complication or something. That's always particularly hard because, I want to be kind of in the business not only of just solving, this medical problem, but, making it, whether it's pain or functionality, to get that back. And if that, it doesn't always happen, it usually does, but it doesn't always happen. And that can be difficult. Or sometimes you have to work a little bit harder and find out what else is going on, because maybe it isn't the hernia, to begin with. And it can be that we fix the hernia and then we have to look for this other problem.
Right. Which can be somewhat challenging for both the patient, and thank God we have a team who can help through that process. In reading some of the qualifications as a surgeon, I'd like to kind of go through these, because a lot of these things that I'm going to list for you have been what people have said about you. And so now we can kind of open that up. But your job description as being a surgeon is fascinating in the fact that you have outstanding training, formal education, experience. These traits that you have and do possess are very successful in taking on and talking with several patients and colleagues of yours. Here are a few listed in which you do have. They state excellent communication, detail-oriented, leadership skills, dexterity, compassion, very patient. You have physical stamina, problem-solving skills, and great organization skills. But that really is the makeup of what our surgeons do in all areas and aspects of it. Do you have anything to add or share in relation to the qualifications or the skills and traits of a surgeon?
I don't know. I guess every once in a while, if you ask the operating room staff, they probably would not describe me as patient. But I think we have a very good team here, really good. I think they were very generous when they gave you that list. One of the things that, for good or for bad, I tend to focus on what I'm doing at the time. So if I'm in a case, I kind of forget about the rest of the world, and that can be good and bad, because you said communication skills. Well, when I'm in there, I kind of forget what time it is, and it would be good if I tell my nurses, hey, this case is going on longer. And sometimes I forget to say that. Sure. So, I get so focused in on what I'm doing, I literally forget about the rest of the world while I'm doing it. And I think that's good. And sometimes when you ask my nurses, they would wish that I would communicate a little better and say, hey, we're going a little slow, or we're going, it's going to take a little longer, or hey, I'm adding on a new case. So, because maybe we just had an emergency come in, and now we're going to do and take out somebody's appendix, and
right.
So yeah.
All right. Do you have anything else to share? Any resources? Anything that our listeners could tag into as far as in relationship? Would it be good for them to look into some of their diagnoses, or when they consult with you, you pretty much explain with them? Do you providing a care plan, treatment plan?
Yeah, I guess I specifically, if they come into the office and they've got an issue, maybe got abdominal pain for a long time and having a hard time figuring out what it is, because they might have a few different things going on, and sometimes it's difficult to get a diagnosis. So, and sometimes it helps to get the history. Mm-hmm. So, there isn't really a test for everything. Sometimes you have to just listen to the story and, come up with what we call a clinical diagnosis. And then we might do a scope, like an endoscopy, like an EGD or a colonoscopy, to take a look and see if that is right. Sometimes there's another test we would do, and sometimes by the clinical history we can say, hey, in spite of having negative imaging or labs that are normal, this sounds like a gallbladder. Let's go ahead and pursue that, and thank God most often we're right.
Thank you so much for coming today. Thank you for listening. Stay tuned for our next episode of Beyond Hospital Doors. To learn more about Sidney Regional Medical Center and services offered, visit us at sydneyrmc.com, or visit us on our Facebook page, or you may call us at 308-254-5825. Thank you for your time, and thank you for your continued support. This is Kimberly Dreyer.